respiratory monitoring. It's a very vast subject. Then after some hesitation, I've chosen to speak about things you can do bedside with nearly all the mechanical ventilator you have in your ICUs. And I'm going to discuss about spontaneous breathing. The idea is also to answer to your questions. Then do not hesitate to raise your hands, whether things are not clear or whether you have comments or questions. And when you speak, don't forget to open your microphone. Then it's easier for everyone to hear you well. Then, these are my conflicts of interest related to different support by brands of mechanical ventilators and mechanical ventilation in general. And first, the first thing I would like to discuss with you is, do we monitor respiratory drive or respiratory effort? Because the difference is important. And to answer to this question, it's important to understand that drive and effort can be related, of course, but are not always the same and do not always give the same information. Breathing is initiated in the brainstem of the respiratory centers as action potentials. They are modulated by a lot of signals coming from the periphery and detected by chemo and mechanoreceptors. Those action potentials travel through the respiratory motor neurons to the respiratory muscles, lead to muscle contraction, and this contraction is going to decrease pressure in the pleural space, in the alveoli, and is going to allow air enters into the alveoli. Respiratory drive is what is at the respiratory center's level. It's the command, and only that. Respiratory effort is the strength of the contraction. Then it's at the muscle level. For example, if you have diaphragm weakness, you can have very low effort and very high drive, because your patient who is awake is trying to obtain enough minute ventilation to control CO2 and oxygenation. In this specific situation, for example, if you monitor the drive, you can have very high values. If you monitor the diaphragm, and the strength of the contraction can be normal or even low or very low. In terms of risk for the lungs of your patient, it's not the same, because what is going to increase the stress at the alveolar level is not the drive, it's the contraction. It's what is going to pull the alveoli outside. And in this specific situation, we could imagine tolerate a high respiratory drive as long as the effort is not high. Except if your patient is very dyspneic, because then you have another problem, and this is clearly related to the drive, the dyspnea. And it's very important to have that in mind. We monitor different things with the ventilators. Some are the command, and some are the muscle strength of the respiratory muscle, and especially the diaphragm, which is the most important inspiratory muscle. Then, first, respiratory drive. Can we monitor respiratory drive at the bedside? We think that we can. Some of you, and the majority of you, don't think that it's easy to do. I'm going to show you that there is an option. Then, ideally, we would like to monitor drive in the brainstem, but this is not possible in humans. Alternatively, we could record what travels, the action potentials that travels along the phrenic nerves. This is possible in research settings, very complicated, then not for the today talk. What is much easier to do is monitoring the electrical activity of the diaphragm. Because when the action potential reach the muscle cells of the diaphragm, they lead to depolarization. And if you record the electrical activity at this level, you have the depolarization that is directly related to the information that comes from the brainstem respiratory centers. Then this reflects the drive. It's possible to do that with a nasogastric tube equipped with electrodes. It's the NAVA system, but not used for delivering NAVA, proportional ventilation, but only to monitor the electrical activity of the diaphragm that reflects respiratory drive. But we don't have that in all our units every day. What we have is PO1 monitoring. I'm going to show you that PO1 is a good way of assessing respiratory drive. Then first, this is the electrical activity of the diaphragm monitoring for those who maybe have this technique. And that's exactly what I've just explained. The signal is coming from here, travel up to the diaphragm. There is a depolarization here, recorded by electrodes. We obtain here the raw signal of the electrical activity of the diaphragm and the ECG, because the heart is not so far. Then after some signal treatment, we obtain here what is related to the electrical activity of the diaphragm that is displayed on the ventilator screen. Because it's linked here, it's a reliable evaluation of the respiratory drive. But this is an electrical activity. This does not reflect the strength of the muscular contraction. It's not because you have high values here that you have a strong effort. Sometimes, yes, of course. For you or for me, it's correlated because we don't have muscle weakness. But for patients with muscle weakness, this electrical activity of the diaphragm really reflects the drive and not the effort. You can also record this with surface electrodes, and there are some works ongoing to assess the reliability of those surface electrodes. It's not bad. It's not bad, and maybe it's one of the things we are going to see in the future. But what we already have is PO1 measurement. What is PO1 measurement? It's the decrease in airway pressure here during the first 100 milliseconds of inspiration. Very short, very early during inspiration. And your ventilator can measure that very easily because this phase here is the triggering phase of the ventilator. And during the triggering phase, by definition, the valve is closed. Then the depression can be measured by the system even without doing a true occlusion after 100 milliseconds. Depends on the ventilator. Some ventilators stop at 100 milliseconds and measure. Other ones use the trigger delay and extrapolate the value at 100 milliseconds. Technical details. What is important is that it gives you a value on the ventilator screen. And why is this value interesting? We're going to discuss that in the next slide. But first, it's important to understand that PO1 has been described in physiology initially. In normal subjects who were not ventilated, and practically occlusion was done at mouth without leaks, and the depression was measured with a pressure transducer. And for those patients, not patients, subjects, we know what is normal value. It's between 0.5 and 1.5. And using the same system for measurement in non-intubated COPD patients, we also know what are values for stable patients. It's a bit higher because they activate the diaphragm to increase minute ventilation, and it's around 2.5 to 5 centimeters of water. It's minus, in fact, because it's a decrease, but often it's not written as a negative value on your ventilator screens. Then we've said that it's easy to measure in ventilated patients because the circuit is occluded at start of inspiration during assisted ventilation. But what are the normal values in intubated patients? Assisted breathing, we don't know. And this is, for the moment, one of the problems, is that we can say that we would like to target normal values for normal subjects, but maybe that those values are not the best one, and this requires additional studies. Then, why? Yes? Open your microphone, please.
What's happening with the flow during this PO1 whenever this occlusion? With flow in airways.
The flow is zero. It's occluded.
It's usually zero. That's what's your experience? Because sometimes I observe it's not zero. Because
it should be zero.
It should be zero.
Because if you don't have an occlusion, then you are going to have an underestimation.
But if you have experience, that is not always zero. No.
Probably depends on the ventilator you have. At least with the one I have, it's really zero. I'm going to show you some traces after that. But maybe it depends on the ventilator. But if it's not zero, we have a problem.
Thank you.
And we are going to see why in this slide. Because why is this PO1 of interest? Then here you have inspiration and physiology of inspiration. Then you have the inspiratory muscle strength contraction that decreases pleural pressure and alveolar pressure. And you can see here, you can see here that you have a decrease in pleural pressure during inspiration. This reflects the contraction. And during the whole inspiration, it's going to reflect the whole contraction during inspiration. Then if we could measure that, the change in pleural pressure during inspiration, we should be able to assess both drive, very early phase, and effort during all inspiration. And we can measure that by using an esophageal balloon here, put in the third or distal part of the esophagus, because as you can see here, we are very close to the pleural space, and by measuring the pressure here inside the esophagus, we can relatively well assess the mean pleural pressure. Then, if we look at the esophageal pressure, we look at the pleural pressure, and we are able to assess the amount of decrease we have related to inspiratory muscle contraction. This is a complicated version and requires the esophageal balloon. But when you occlude the airway, as it's shown here, in fact, you occlude the ventilator circuit with your ventilator, you have an equilibration of the pressures everywhere in the thorax. That means that by looking at the decrease in the pressure in the airway, you assess the decrease in pressure in the alveoli and in the pleura, as long as it's occluded. And that's why it's important to have zero flow. Because if you don't have zero flow, then you don't have the occlusion, then what you are going to measure in the airway is probably lower than what you would measure with the esophageal balloon. But if you have an occlusion, just looking at the decrease in airway pressure during this occlusion, you can assess the decrease in esophageal pressure. And this is very interesting because you get two things. You get the decrease during the whole inspiration, which is occlusion pressure, and you get the first 100 milliseconds here decrease, which is PO1. Then by measuring PO1, you measure the very initial decrease of pleural pressure. Then you are able to assess what occurs very early in the inspiratory phase. You can see illustrated here on a curve taken from the ventilator, the decrease in airway pressure that reflects the decrease in pleural pressure. And this measurement is very interesting because the occlusion is very short. And that means that it is not perceived by the patient. And it's not going to change respiratory rate, tidal volume, etc. And in addition, the system is occluded and it's very early during inspiration. That means that the value is independent from the respiratory mechanics, independent from resistance, because there is no flow, because it's occluded, and independence from compliance, because we are at the very start of inspiration and there is no volume in the lung. Then this is independent from respiratory mechanics. And this is nearly independent from the presence of respiratory muscle weakness, because we are very early, and this very early phase, even in presence of weak muscles, it's not changed, at least except in the very, very, very severe situations. The problem is that there is some variability in the measurement, and to really be reliable, you should do 3 or 4 times the PO1 measurement and average, but it's easy. Then, not perceived by the patient, does not change the respiratory pattern, independent from respiratory mechanics, independent from weak muscle, but variable. Very easy to do. Then you can really monitor the respiratory drive using a ventilator. And you can see that this PO1 really reflects PO1. First, if you take healthy subjects and you increase CO2 in inhaled gases, of course it's an experience, you can see that the higher PaCO2, the higher the PO1, because drive is higher. If you take patients under ECMO, and if you change VV ECMO, the gas flow, here you have 100% of assistance, and then you decrease the gas flow up to nothing, and you can see that in parallel you have an increase in PO1, which reflects the increase in respiratory drive. And if you correlate the electrical activity of the diaphragm, I showed you measured by the NAVA catheter, with PO1 measured by the ventilator, you can see that the correlation is very good. Then this simple measurement really reflects your respiratory drive. Now, can we monitor respiratory effort at the bedside? Yes. First, and this is probably very important, clinical exam may help you. May help you detecting that inspiratory effort is probably high. But of course, you cannot quantify with clinical exam. When you have recruitment of the accessory muscle, when you have a rapid shallow breathing pattern with low tidal volume, high respiratory rate, usually you are nearly sure that you have an increased respiratory workload. When you have an abdominal paradox with an inward movement of the abdomen during inspiration, this probably reflects diaphragm fatigue. All those parameters are highly suggestive of increased work of breathing, but you cannot quantify. But this can be useful. If you have patient with acute respiratory failure under non-invasive ventilation, you change the parameters and you have no improvement in the clinical status, you are probably going to fail because of increased work of breathing. Then this is important to have in mind. And then you can use what I've showed you before. You can use this occlusion pressure. Same system as for PO1, but this time you look at the maximal decrease of airway pressure during the occlusion. And this reflects the muscular pressure. And in a quite big series of patients, team from Bertoni have correlated the values measured with the esophageal balloon and with the occlusion pressure. And they have shown that if you use the occlusion pressure and you does times 0.75, you assess very reliably muscular pressure. Normal value for normal subjects is between 5 and 10 for muscular pressure, which corresponds to 12 to 15, about 12 to 15 for occlusion pressure. But again, it's for normal subjects. You see here in the original publication, here you have airway pressure, esophageal pressure, an occlusion, and you see the concomitant decrease in esophageal pressure that reflects pleural pressure and in occlusion pressure. And here it's done on a ventilator screen. You just have to play a bit with the scales, but you can measure the maximal decrease. And here we have a very high occlusion pressure reflecting a very high inspiratory effort. Same thing here with another ventilator. Be careful, the total value is the minimal value plus the PEEP. It's the depression, the difference for occlusion pressure. And here with another ventilator, also the same. And this is the correlation between occlusion pressure and work of breathing. Very good. It was very good for muscular pressure, but also for work of breathing. And we have ideas of what are normal values, at least for normal subjects. And for occlusion pressure, we know that for normal subjects, normal values are between 5 and 10. Unfortunately, this does not mean that we should target this value for all our patients. We don't know what are the normal values of the intubated patients for the moment. This is the third thing I would like to discuss with you. There is something else you can do with your ventilator. You can do the end expiratory occlusion to measure PO1 and occlusion pressure. And you can do, during assisted breathing, an end inspiratory occlusion. And what do you measure usually during controlled ventilation by doing plateau pressure? You measure what you have in the alveoli, the pressure you have in the alveoli. And this way you assess the stress delivered to your lungs. And you can do exactly the same during assisted ventilation. If you do the occlusion during inspiration here, you can measure plateau pressure. This plateau pressure reflects what you have delivered with your positive pressure and what your patient has done with muscle contraction. Then you can see the stress that goes into the alveoli. Here you see that you have a strong effort, huge decrease in pleural pressure, esophageal pressure, and you have an increase in plateau. On the right, you have a lower effort, and you have no increase in plateau. Then the plateau pressure during spontaneous breathing reflects lung stress due to the positive pressure of the ventilator and to the patient inspiratory effort. The target basically is the same as for controlled ventilation, lower than 30. And in retrospective series, high values of plateau pressure during spontaneous breathing have been associated with increased mortality. Easy to monitor. Then we can do every day for our patient under assisted ventilation. However, sometimes it's difficult, and this is important. We need to have reliable values, as always, for all the monitoring systems. And to tell that your plateau measured during spontaneous breathing is reliable, you must have a rapid increase here in the phase that is written 1. Then the duration of the plateau should be long enough, around 2 seconds, and the plateau should be a plateau. It should be stable. In my experience, it's possible to do that in more than 90% of the patients under pressure support ventilation with some training. But in about 10% of the patients, you just have that, and that cannot be interpreted. Then you have to check the aspect of your airway pressure curve before interpreting the plateau you measure during spontaneous breathing. If you prolong it, the problem is that then you are going to have a new inspiratory effort. And then you are going to have a decrease here. It's going to give a plateau, and then a decrease, and then again the plateau, but it's difficult. And the patient feels this maneuver. On PO1, no, because it's too short, but here it's during all inspiration, then it's sometimes easier to tell the patient, I'm going to stop the machine. It's going to be a bit strange, but it's not dangerous, because they really feel it when they are awake. And you can see here how it looks like again. And you can also measure the difference between the plateau and the set inspiratory pressure. And this gives you another index, which is called pressure muscular index, which also reflects the muscular pressure. The measurement is of interest, but the concept is very important. When you deliver pressure support ventilation, pressure regulated mode, in a patient who is breathing spontaneously, you can have a barotrauma, because the pressure you have in the alveoli is what you deliver here, plus the contribution of the muscle contraction. This is a very important concept during spontaneous breathing. Yes?
May I ask something? In this setting where the patient is actively breathing, if we do not have an esophageal balloon in place, so to monitor the esophageal pressure, are we absolutely safe to say that during the inspiratory occlusion test, this measurement of pressure is a plateau pressure, not an expiratory pressure during active expiration?
If you have a real plateau, it's okay. If you have an activation of the expiratory muscles, which can occur sometimes, you are going to be unable to have a plateau. Then if you look at the quality criteria, then you are sure that you have a plateau pressure. And as you can see here, this PMI, then the difference between the plateau and the set pressure, is very well correlated with the muscular pressure, as long as the quality criteria are met, and this is important. Then it's really quite easy to measure muscular pressure this way, too. And this is how it looks like on different ventilators. You can see that here there is the occlusion. We have no flow. You see here the increase in plateau, which is big in this example. And we have here a plateau of 23. I don't have the settings, but it was probably around 13 or something like that. Here again, you have the occlusion here, and you see that the plateau is higher than the set values, and the difference between the value here, maximal value, and the set value is the PMI. And with another ventilator, you also see the plateau here. In all these three examples, the quality criteria are met. Then you can use the values. And there is one paper in the literature that used this concept in monitoring the patients and correlated with clinical outcome, short-time outcome. It was during COVID. And this group, in a very small group of patients, 28 patients, measured PO1 and occlusion pressure the first time they switched their patient from controlled to assisted ventilation. And they showed that the patients who are going to worsen in the next 24 hours were the one who had high PO1 and high occlusion pressure. But it's in negative value, be careful. And the predictive value of those two measurements to predict worse evolution of those patients and coming back to controlled ventilation was very good, with a threshold of 4 for PO1 and of -10 for occlusion pressure. Then this is the first patient data suggesting that we could use that on our daily clinical practice to set the ventilator and not only to measure, but probably that it's a very promising approach. Then bedside advanced monitoring of the respiratory effort using only your ventilator is possible. PO1 for respiratory drive, occlusion pressure and PMI for inspiratory pressure, and plateau pressure for assessing the stress applied to the lung. The currently recommended values comes from physiology, normal subjects. I'm not sure that those are the value we should target on our patients. A lot of groups are working on these specific questions, but for the moment we don't know. And those target values and the way of using those values to set the ventilator have to be validated prospectively. Thanks for your attention.